Okay, we're going to spend the next 45 minutes addressing some questions that some of you submitted for this panel. Before we do, I just want to thank again everybody, all the speakers that came today. I know it's a privilege for us to be able to hear what you have to say, and so we appreciate it. So one of the questions that somebody from one of the attendees asked was, can you discuss, and I guess this would go more to Dr. Tonigan and Beverly Roesch, can you discuss the differences in effectiveness of AA and group therapy in diverse client populations?
Go ahead.
I want you to start off with that.
Okay. Well, I mean, similarities and differences, of course, the most obvious statement is that group therapy is led by a professional, certified professional. AA is non-professional by definition. And what was the second part of the question?
Diverse
population. Oh, diverse population. Well, I can't speak to group therapy. I mean, what we're seeing in the 12-step, the community-based AA, that it seems to be appropriate for diverse populations. We see similar magnitudes of benefit across adolescents, comorbid disorders, polysubstance abusers, and those with only an alcohol use disorder.
Yeah, I think that properly run with enough safety maintained in the group context, and I feel like the two, in our group work, in addition to doing a lot of trauma work, et cetera, and a lot of multi-systemic family work, it translates well back into the 12. I mean, they're attending 12-step meetings, and then the cohesion and the trust that we're building in group work translates well into the 12-step meetings post-discharge. And I'm trying to think if I can think of particular populations that were more resistant to group therapy. And to be honest, off the top of my head, when I worked at Highland Ridge for a while, we worked with an extensive Native American population. And I think it took them, they had a lot harder time warming to the group therapy context. Did better in groups with each other only. And adolescents can be challenging, but they love experiential techniques. So in my sense, if you can get them up and running on experiential, they do very well in group.
Thank you. I guess one point to follow up on that too is what any ideas though, if a clinician's like recommending AA to a client, what pitch should they make? I don't know if anybody on the panel has thoughts on that. If I'm a clinician, I want to make what pitch should I make to the client?
Pitch all the time, you know, the love, the support, the connection, and again, we're also careful, like you said, to try to know what the better meetings are, because there is some research. If you send them to 3 lousy meetings in a row, you've lost them to AA, at least for quite a while. Is that your experience, if they don't get to a good meeting?
Right. And I would say, I don't think we should be AA-centric here. I think that's a very important point. There's many other what seem to be effective mutual health programs. Women for Sobriety, Life Ring, Rational Recovery.
Yeah.
There are many things. If someone was repeatedly resistant to that recommendation of AA, I'd say, well, maybe, I'd first find out why. If it's one of the common statements of, well, they're a religious organization and I don't want to go there. Or my uncle went there and he got worse, or, all the reasons that people would have, good reasons, then you seek out alternative opportunities to provide mutual social support for those individuals.
And I would admit to being somewhat AA-centric.
Okay. Yeah. I'll just comment in terms of a prescriber or a provider perspective. A lot of people think that, I went to one of those groups, I didn't like it. And the issue is that you need to kind of roll with resistance a little bit. Every group is a lot different than the other groups. And so oftentimes we're telling people is to try one group. If that didn't work, doesn't mean that another group won't work. Because it really is where predominantly a lot of people do get great quote-unquote treatment and really great camaraderie over time. The other thing that's really important is that you develop that mentor-mentee relationship, that sponsor relationship, and you really want to find the right sponsor, because it really does help in terms of recovery on a long-term basis.
And one more thing. Get to some of these meetings yourself as clinicians, like you recommended. Get to know the lay of the land, and you can describe it from the inside, and it helps that bridge as well.
And we actually end up with a very complex discussion of goes way beyond here, is if your client for medical assistance is on methadone and you refer to AA or 12-step program, there might be additional counseling involved about what one will share or not share, at least in an open meeting setting. The few studies that have been done on medication use indicate it's a very complicated relationship of AA philosophy and membership with the use of medications.
Yeah, I just want to share, this is actually sort of my personal experience that I'm a big AA fan. I really appreciated having the talk about that. But when I talk to my patients, you know, I always tell them, if you're going to go to AA meeting, if the newcomer's not the most important person at the meeting, you're at the wrong meeting. That's my own personal belief, because, you know, we're all there to help each other and stuff. Also, you know, if somebody comes back into a meeting and who's relapsed, you know, it shouldn't be, you didn't work a program, you screwed up. It should be, man, I'm glad you're alive, I'm glad you're back, what can we do to help you? So you want those, and it's right, you know, I just want to share one personal experience. I went back to my hometown of San Luis Obispo, and I went to an AA meeting there, first time I'd ever been to one there. And they had this thing where the guy would share for 5-10 minutes, and he shared, he was a young kid, and he started talking about how he'd gone to multiple rehabs, run from all of them, including Circle Lodge, which was funny, you know, that's thing. But then he said, he started sharing about how he finally realized there was a higher power when he got stoned and drove and killed 3 people, but the witnesses could not get their story straight, so he got off, and that was God saving him. I was freaked out. Okay. Now, fortunately, I had announced that I was a visitor from out of state, and one of the people, and then you could tell that some of the other people in the group started bringing up things, and they started getting a lot of people sharing that. And one of the people in the meeting came up to me and said, you know, you're a visitor. It's not like this. It's not like this. And I came back again a couple days later, and it was totally different. So I sort of share that sometimes with them, that, you know, like you say, they got to go back a few times, but you do have to find the right meeting. And it has to be more of a compassionate, you know, we're here to help you kind of meeting.
Yeah, and just to realize that, I mean, I'm sure you all talked about this earlier today, is that not all meetings are really to share your story. I mean, some are very didactic in nature, and you get guest speakers to come in and talk.
Right.
You don't, and you have to really relate that to the potential patient or client, to say that, hey, you know, you find a meeting that works for you.
So with the clients or patients who are receiving medical or medication-assisted care, I mean, what do they have to navigate? What is that conversation they have if they're going to go to these abstinence-based, like 12-step groups or treatment programs, but particularly AA? I mean, what is that discussion like? How do you have it?
Well, so again, you find the right group, right? There are some groups that are very accepting of that, of medication treatment, but you're under no obligation to disclose your medical care.
Don't tell them.
And usually what I tell people right off the bat is that if when you go, you don't have to disclose your medical history. That's not an obligation. That's not part of any of the steps or any of the work that goes on. Until you feel comfortable disclosing something, then you can. So again, it's a kind of that prelude. There's a lot of misconceived notions. I actually don't think that the abstinence and kind of harm reduction models are too different in many ways. I mean, you can actually mingle them very well, and it really provides a resource. Again, it's that crutch that you're getting. By the way, before we go on, thank you all for being here late in the day. It's Friday. It's a beautiful day outside. You must be addicted to addiction topics. So I appreciate you guys being here.
One other thing.
Hey, want you.
Hey, Corey, I wanted to say, I think it's in As Bill Sees It that he actually says that there's nothing, that you can take medications as prescribed. Okay, yes. So it's, you know, some of these hardcore people say it's not, but actually I'm pretty sure it's in As Bill Sees It that he says that, you know, you take what you.
It really comes down to coaching them.
Right, but I agree with you. Don't tell them. I mean, there's no reason to tell them what your medical care is. You're going there to get support for, you know.
Yeah, and certainly not early on when they don't have their
Right.
voice yet.
Right, exactly.
Yeah.
So this one, where is the ASAM criteria being taken into account when expanding treatment to non-specialty settings? Comment to that question is I worry it would be like having your primary care provider perform eye surgery. Could you do so in an emergency, but you could do so in an emergency, but at risk lack of training. I don't know if you could.
Yeah, so I'll just mention. So the ASAM criteria, as many of you know, it really provides a groundwork for where treatment occurs, addiction treatment occurs, but more importantly, kind of criteria for admission and maintenance and discharge. And it's really recently been revised, and many states actually use this in terms of their classification of different treatment programs. Remember, if you're dealing with primary care or office-based care, it's really outside of that treatment paradigm in many respects, because you're not part of You're part of normal medical care by normal medical doctors in normal medical settings, right? And that's what the push has been. The whole idea of SBIRT, I know Dr. Cochran mentioned that. I mean, that's a whole paradigm shift. There's nothing about SBIRT with regards to ASIN criteria. So it really is to try to open up the avenues to provide that longitudinal care model, so that then providers like me or you can say, oh, I'll follow you long term, but oh, you need to go to a 3A facility, or you would be really good for this type of program, and that's how it's really interdigitating with office-based settings.
Thank you.
Eye surgery. This is an eye surgery. Yeah. So, I don't want to talk too much. So, more people die of aspirin consequences than any of this medication treatments we just talked about on an annual basis. Okay, this is not rocket science. The rocket science of a lot of the medication treatments is that we're trying to expand to a workforce that's not used to it. And in fact, everybody get worried is about induction and starting the medication. It's actually very easy. It's harder to put people on insulin in many ways than put people on these treatments. So, this is not, now, does that mean that everybody's appropriate for office-based care? No. And in fact, just like not all people can be treated for depression in primary care or diabetes in primary care, you have to make a balance about what you're comfortable doing. And so we're not trying to make office-based settings or pharmacy settings to be treatment programs. That's the wrong approach. If you do that, you're doing the wrong thing. Treatment programs are there to take care of those really, really people that need that type of care. And they may not be appropriate in primary care.
So another question, what can we do to decrease stigma? Several of you talked about in your talks.
I'll mention one thing. I like to talk, you guys tell me already. I think the language of addiction is a really big problem in our field. We talk about people being clean or dirty urine. Everybody's urine is dirty. Your urine is dirty in my eyes, okay? That's inappropriate. We don't call people cancerous, right? We shouldn't be calling people addicts. That's just my very firm opinion. We have to think about people as people with a disorder or a disease. And if we start to think of a person-centric language, non-pejorative terms, I think we then reduce the stigma associated with it. So that's my that's one of the, so I cringed when I said addict earlier today with you all, because I don't like saying that word. I think that if we have to go a long way to destigmatize our language, and that's one intervention that we can do.
So real quick, to follow, if we have that belief, I'm in a meeting and I say, I'm Corey, I'm an alcoholic. It's part of the language, of the culture. That's okay. Is that different than your?
It's different.
What you're saying?
Yeah, it's different.
And I also just scream it from the rooftops if you have, so many of you have it in your families and your friends. The more we're willing to speak up in a lot of different contexts, when we hear people making, or that do not understand an illness, and when we hear those prejudices, to speak up about it and own the fact that it's going on in our families. It's going on in their families too, usually somewhere. And if we keep speaking about it and owning it, that it's going on in our own lives and other people's lives that are close to us, I think that helps. Anybody else on stigma?
Yeah, Bev.
Yeah.
Yeah, remember when I said, I was a doctor, a dad, and a dude, and I was just here to share my experience, strength, and hope. And I wanted you guys to go out and share your experience and strength and hope. That's the key. We got to get education. You go out to the schools, go out to church groups and stuff, and talk about it, because it's really getting the word out and talking about it, because it is a problem. And stigma really hinders our objective. It hinders our treatment. So the more we can talk about it to people, I think the better off we'll be. Remember, it said, suicide, mental health, and addiction are the ones we're still lingering on with stigmas.
I'll also add that as we move identification and treatment of patients into settings that are non-specialty settings, primary care, pharmacy, OB, whatever setting it is, and it becomes ubiquitous, and we're talking about it everywhere, I think that makes it more normal for a lot of people.
Right.
A friend of mine was at a fireside at LDS Church, and she was talking to the bishop, and he had said, if the congregation only knew how many other people were struggling with it, if there was a way to open up those discussions more in a church context, it would really take some of the shame away, you know?
It's an interesting point around here.
Another stigma intervention that we're seeing, and this is actually being studied right now, is this whole idea of record sharing and communication between addiction treatment provisions, service provisions. So many of you are social workers. You may be working, in a setting, healthcare setting. If you tried to get understand even what happens in a 12-step based program or even a methadone program, we don't have any communication back and forth between that part of the treatment system in addiction. So we have to break down some of the regulations and rules to help share that information, because then providers know. When I send someone to a cardiologist, I get a report back and they tell me what to do. That doesn't happen if I send someone to a methadone program. And that integrating would be much better and much easier. That would destigmatize a lot of things.
Adam? This is a little bit of an aside, but I was at an AA meeting once, and there was a guy there who was sharing that at church, LDS church, that people were shunning him, and it just floored me because, and I just want to make sure you guys understand this. I don't know if you know that the LDS church has one of the largest, most progressive addiction recovery programs out there, okay? And you can go on, I don't know if it's LDS.org, and there's 12 videos and stuff and things. So it just shocked me that a lot of people who are in the LDS church and church don't understand that the church is not anti-addict. They know that there's, like you said, there's a lot of people out there who have this problem. The addiction recovery program is huge, okay? So we just got to get the word out. It's amazing how many people don't get to know.
Dr. Tonigan, somebody wanted to ask you, you said atheists don't do spiritual work of the 12 steps and have equal outcomes to their agnostic and believing counterparts. However, you also said that behavioral steps were negatively correlated with abstinence, while working the spiritual 12 steps is positively correlated with abstinence. Can you explain this?
Well, somebody was listening.
They're addicted to addiction.
But no, it's really insightful. I think what these people are doing, and let's put this in perspective. Nationally, we suspect about 5 to 7% of the U.S. population are atheists. So we're talking about a very small percentage group. I would think that those atheists who do affiliate, who do not practice a spiritual program, or, I need to be careful here, who might but don't receive any benefit from doing so, also are not working the behavioral steps. Okay, they're relying on the social support of AA. The meeting attendance, the social activities, the phone calls, and those sort of things. I think when you talk to members of AA, there are some who will say, I worked the first 12 steps in the first 2 weeks, and others who look like, well, that's impossible. It took a year to work through the steps, or what have you. And so there's a long latency period for all members in working through the steps, and I think the atheists can kind of just go along with them and derive the social support, as well as the self-efficacy, because when we think about abstinence-based self-efficacy, it should come as no surprise. What it's saying is, if I did not have a drink today, I'm more confident I cannot have a drink tomorrow. I can keep from having a drink tomorrow. And I think that's true of any kind of behavioral habit we try and change. And so atheists, why would they be any different? I've been abstinent today. I was abstinent yesterday. I believe I can be abstinent tomorrow with the support of people.
When it comes to atheists, I actually had a whole group of people who were really sort of turned off by the God thing and everything. And there are non-secular 12 steps. I have like 6 of them on my computer I downloaded and printed out for them and handed to them. And so there's even a book that's a non-secular, a book on it. So you can find stuff for them and provide them with things that'll help them get through that.
And I think also we could like expanding a notion of what spirituality is,
Right. Right.
and the sacredness of the group and the upliftment of, the universe and the cosmos. And I find atheists very creative. They may not believe in a biblical God or a strict religion, but they come up with very powerful ways to engage spiritually, in my experience.
That is a wonderful point. Project Maps. This was that was 20 years ago when we were recruiting these people. And I still remember this one client because at the baseline, when we had an assessment, would you describe yourself as religious or spiritual or agnostic or atheist? This person looked me in the eye and said, I am a secular humanist. And, which leads towards this idea of, I understand a collective consciousness, I recognize that, but I wouldn't regard myself as spiritual. So, yeah, I think you make a really good point.
Thank you. Please speak to the prevalence of attachment ruptures, wounds in people with addictions and implications on treatment.
So repeat the question again.
Attachment wounds are very prevalent amongst addicts.
Speak to that and implications.
Group work, individual going back and doing the work of healing those original wounds, and rejoining the human family, and all those strategies, which those of us who are working residential treatment are at all the time in a variety of fashions, is really critical.
Yeah. I'll just point out, that's another anti-stigma component, right? So as patients go in and out of treatment or care, this is very difficult to reestablish, their social life. A recovery is a recovery not just of the addiction, but really of their life. And having a very clear, as someone says, I'm sorry, or making amends for past discretions that they've done, to destigmatize the disorder, you as the recipient of that apology or that making amends really should accept it. And that's often very difficult for many people to do.
I'm kind of curious about your thoughts on this. So what do researchers need to know? What do researchers need to know about practice, and what do practitioners need to know about research?
That's
Gary.
it, you guys.
You're getting that one.
So I could go on a lot for this. I won't. So there's this ivory tower mentality that we have, that we want to do evidence-based work and prove something that works. The big push right now in addiction research is what we call implementation science. And implementation science means that we're bringing the treatments and the paradigms of how well it works and actually implement it in real-world practices. So there is a big push to do that, and that there's even large institutes. One of them is like Macquarie, is a huge grant-making institute in the country, and their whole goal is pragmatic, real-world studies that work in real-world settings. And so, and the implementation scientists, like I am, that's the research that I do. How can we get this stuff into real practice? And I think the practitioners often think the researchers are cutting out rat brains, right? Or doing monkey research or something like that. That's not, a lot of research in this field is not that anymore. It really is getting it into real world practices. So I think that's going to be a big push. You're going to see a lot more people like going into community pharmacies, or how do we integrate primary care with 12-step programs? And those are real-world challenges that we have to deal with, and that's what research now is moving into.
And also, finding ways to interact with each other more is important. Just
Like
like
today.
these, I've learned a ton from being here, but I don't get to interact with researchers that often, and I'd like to find a context to do that more.
Talk to parlays.
Yeah, come to the University of Utah.
Yeah.
Once a month, we have parlays.
Well, tell them what that is.
It's essentially an opportunity for researchers and clinicians and community practitioners to get together and to have a conversation about addiction. If you're interested, we can take your information. We can put you on our email list.
We'd love that.
And it's free parking.
And food.
That makes food.
The food is fantastic.
Any
Once a
cup,
month, yes.
any
We offer
cupcakes?
CME
Got any
oftentimes.
cupcakes there?
Yeah.
Cupcakes. So I would say, as a researcher, what do I really appreciate from clinicians? I oftentimes don't appreciate the complexity of the patient or the client or the individual's life. As I plan intervention, as I plan a study, it's really helpful to know and to think about and have kind of explained to me all that's going on with the individuals that we might try to help. That's something that oftentimes when you think about researchers, you think about linear associations between this and that, and it's really hard to encapsulate or to think about all that's going on in a person's life. In the flip, I think it's really important for practitioners to know that although there is an evidence base out there, it's extremely limited. Oftentimes the studies that we do are these linear associations, and I think as practitioners, one of the things that before I came to Utah, I did a fair amount of teaching at Pitt. Something that I would really encourage students to think about is, when they're looking at the evidence base, where's the limitation of the evidence base, and how does that potentially need to change for my particular client in my particular situation, and going out and trying to find additional information to help shore that up, because evidence-based practices oftentimes are established on very homogeneous populations within very controlled settings, and if a practitioner implements that intervention, and all of a sudden it doesn't work, it's not necessarily because the intervention is bad or something went wrong, but it's because there's limitations on the scope and the kind of the generalizability, the external validity of the intervention itself. So to give researchers a little bit of to believe what they say, but also at the same time understand that there are limitations. So I think that's how I would respond.
Thank you. So a question from the audience. Any ideas for how to help patients or clients work a more spiritual program, or to find a higher power when they have none?
For one, we try to expose them to a lot of different modalities and see what might stick. Maybe a Native American approach, go to a sweat, teach them meditation, and then I'm always amazed that sometimes they'll have a spiritual breakthrough with a horse. So as many ways that we can intervene and open up to a spiritual feeling, or so to me, it's like, what might work with this individual? What might light his fire? What might wake him up to a larger reality? So for us, we try a lot of different methods to see if we can't find a piece that will click. You got something on this?
Yeah, actually, you saw I put up that thing with all the talk, some of the talk, Dumb and Dumber, and one of them was Dumb and Dumber Spiritual Resuscitation. And it was based on the fact that after Alyssa died, I actually hated God and everybody else. I mean, I was pretty pissed off, okay? And if you even brought up the word spirituality, it just wigged me out. And so I had to myself come to some kind of understanding of spirituality. And so, I had the one talk is like secular versus non-secular spirituality. And I think when I talk to people who have issues with it, you've got to try and explain to them that, spirituality should be part of religion, but religion's not part of spirituality. Spirituality is more of a personal kind of thing. And you have to come up almost with your own little definition of it. And me, I finally came to it. It was like faith in myself and my ability to improve and the actions to do that. Now, some people wig out with it because they use the word faith, but that's not necessarily a religious thing, But I even mentioned in my talk, I think for me, the spirituality, loss of spirituality and the addicts is the loss of hope, okay? The loss of, hope in a future and stuff. So again, I just try and talk to them about the fact that, you don't have to necessarily believe in God to be spiritual. Spirituality is more of a personal thing, and it's more about you and improving and having some kind of hope, okay? And I know, again, from my own experience, I had this wonderful bishop that showed up at my house like a couple times a week. I don't know how he put up with me, man, because I was pissed, probably swearing, and I'm pretty sure a few times I was drunk. And but he just hung in there with me, and I finally ended up going back to church, but I really had to come up with a definition of spirituality that had nothing to do with God at the time for me. And that's where a lot of these people handle. And you'll see a lot of them will finally come up with their own identification or definition of spirituality, and they may even end up with that being part of God down the road.
Yeah.
But we're dealing with a lot of pissed off people, okay,
Yeah.
and who are angry at life and angry at the world. And I was there, so.
And I think a lot of them, proper representative church, I love to see them find the way back to the religion of their youth, if they can get through whatever happened to them, the woundings within that church or whatever. Lots of times when they can find their way back, it's really powerful, but they've got to go through the process of being angry, feeling judged, all those things. When that can happen, I think it's a preferred outcome if they really can find their way back, and if they can't, you know, there's a lot of different alternatives. I find a lot of residents love Zen Buddhism for some reason, because it's non-theistic. It's more about waking up in this life, and it doesn't involve a deity. So sometimes exposing them to things like that is helpful.
Right. I think, you know, we live in a world that's, you know, popping all the time. It's one thing after another. And William James himself is quoted in the big book, in the appendixes. You know, there are two types of conversion: the Ebenezer Scrooge conversion, you know, where I'm suddenly religious and holy, and the more educational variety. And what that implies is that we as providers and researchers, this is an organic process that happens that requires patience on our part as we watch it, measure it, and support it. How I would tend to support that is I find it's very hard to have hope, gratitude, appreciation, and not at the same time have some appreciation for the wonder of the universe that we live in. So that's how I would tend to move people who were resistant to a theistic spirituality into at least a recognition of there's something larger than themselves in the universe, and start with the issues of promoting gratitude in their life. But also patience. I can't speak to the clinicians here, but you know, we're funded, and if we can do a 12-month study, that's about as far as we can typically go out with the funding. Some of these things that we're speaking about here take much longer than that to really materialize.
The only thing I'll just add to that, and I agree with everything, is that, you know, I think many of you reflected on your life, kind of it's a very stressful society we live in right now. And you often have things that you do to get away. Maybe it's a mindfulness meditation, or maybe it's a hike, or maybe it's, you know, to walk your dog. And all those things, at least in my eyes, are what we're talking about. You're escaping, you're thinking, you're calming yourself down, and in many ways you become more spiritual because you're doing it and you're moving toward kind of that movement. So if I start explaining that to patients, they kind of get it then. They're like, oh, okay. And I say, well, maybe a 12-step program may be a little bit more intense than that, but it's a very similar concept. It's a continuum. And I think people gravitate to that. How many people here you do yoga or meditation? You don't have to raise your hands. I mean, we do this because it makes you feel good, right? You to escape, and that's very helpful for a lot of people.
Yeah.
Can I make a comment in response to that?
Yeah.
Because I run into that problem a lot with people myself.
Yeah.
And sometimes I'll ask them, like, well, if you had 72 hours to live, what would you do?
Yeah.
Because that's kind of it taps into a spiritual nature that maybe they haven't thought of. It's like, what do you believe is right?
Right.
Do you think there's a good Would you go and get high? Could that last over time? Maybe. If your addiction is your higher power, maybe. I don't know. But kind of like helping them see what is the ethics that they believe in versus
Right.
a god or a deity or something like that. You know, that can really help.
I've also, this is going to sound a little weird, but in breath work in our facility, I've had about 10 instances where, for some reason, they felt visited by a deceased person, someone that loved them. And it was transformative. One time, that opened up a spiritual experience for them. And I'm not sure what it is about breath work that helps to create numinous experiences, but really 10 experiences of people feeling that they were visited by a loved one who passed. And one guy said, I was an atheist until today. And it was, you know, I don't know how to explain it. Somebody needs to do research on it, but I certainly don't discredit it. I'm in awe of it. It's one of those vital spiritual experiences that happens suddenly. But I'm grateful for it when it happens sometimes.
Yeah, I just was reminded, I mean, I totally agree with that. The other thing, too, is that we have now apps on our phones or clocks that tell us to breathe, to stand up, right, to walk, right? So even our marketers out there realize that getting away a little bit and trying to think about what is really important in life is based. We have to do it part of our side, not just patients with addiction.
So is there a question or two from the audience?
Yeah.
It's Vince Barton.
Yay!
So let's start here.
What do you think about Proposition 2 here in the state of Utah?
What it is.
It's medical marijuana.
Marijuana.
All right, so why don't we come back next year? We'll talk about marijuana. So, great question. So I'm an addiction medicine doctor. Okay, so I'll give that as a caveat. I've also done work in terms of medical consequences of long-term use of marijuana, and there are medical consequences. But every substance that you have, if you ingest or imbibe or whatever, including cupcakes, you're going to have consequences, right? So that caveat. The problem that I see, and well, I'll give you two comments, and again, we can talk forever, but I'll just keep it brief. First, many of the studies with regards to the effect of marijuana has been compared to nothing, right? So imagine someone with depression, and you don't give something to somebody with depression, but you give another person chocolate. Which person is probably going to feel better? The person who didn't get the chocolate or the person who got the chocolate, right? And so many of the very bad studies that are out there are really comparing marijuana to something else, okay? And a lot of the effect of marijuana on medical disorders is really to escape. It's you kind of feel away, you forget your whatever you're dealing with, and that's part of the effect of this. So as a researcher, I'm saying I'm not sure that that's compared to normal medical treatments. It's good, but I think it's also an indictment of our medical system that people can't get good care, and so they're reaching for anything in order to get better. So that's just one caveat. The second issue, though, is that when states have, and I just reviewed a lot of these papers, when states have legalized recreational marijuana or even medical marijuana, we've seen a dramatic increase in the amount of people who are using it recreationally and or getting cannabis use disorder. It's estimated that about 10% of people who are on long-term marijuana will have an addiction to it. And I have treated patients with addiction and to cannabis, and it's not pleasant. There are some consequences of that, and people do withdraw from cannabis. Some people do, and some people have a lot of deleterious part of their life. So, we've seen where states have legalized it that people get into more trouble because their access is there. Kind of think about the opioids. We have more access to opiates, and now we have a big problem. And there are some people that are thinking the same thing with cannabis. Now, that all being said, cannabis is a pretty minor substance in terms of harm, but it does cause people to do weird things, and motor vehicle accidents are up, and DUIs are not about alcohol anymore in some states, they're about cannabis. So we've got to be a little bit careful about the public health effect versus the individual effect with these laws. I can't tell you whether I'm going to vote yes or no on it, but I think I really think we should be very careful about the addiction issue. And if we are going to have medical marijuana in the state of Utah, it should be regulated. And it's hard to regulate doses and treatment of marijuana.
I'm all for getting the addicts out of prisons and jails. It's crazy. We've got to do something about that. I know it's a different issue, the decriminalization of warehousing all these really minorities and folks without resources to fight these charges in our jails and prisons. We incarcerate more people in our country than any nation on earth. Got to find a way to stop that. That is not helpful.
I'll mention one more thing. I'm sorry. I totally agree with that. I mean, I think, where the number one treatment system in the United States is? It's in jails and prisons for addiction, right? That's where people are first getting introduced to group therapy, individual therapy, even medication treatment. And I really think it's an indictment of that we're treating this disease as a criminal disease rather than a real medical disorder.
Somebody had a question?
Let's come back next year and talk about marijuana.
Yeah.
Okay.
Maybe we'll all smoke it.
No, I want the candy.
Just a quick follow-up to that. Do you think it's possible that cannabis prescription could be a better alternative for pain management than opioids?
There's a pretty good JAMA review out there that looks at the benefit of marijuana compared to other medications for different disorders, for different health problems, and I think the evidence is pretty mixed. I think in terms of clinical trial information looking at cannabis, I don't think it's There's a lot of anecdotal, popular information out there where people talk about, what it does for them. But in terms of what we call high-grade research that supports that, I don't believe it exists at this point. I will say, and I know that there's been mixed information out there, but there have been a number of reports that show when states do legalize overdoses, opioid overdoses reduce. Legalize marijuana, opioid overdoses reduce. So I don't know if it's treating pain or if it's treating something else, but there is that.
Yeah, just before we go past that question, I think that was a great question. Again, it's mixed. As I put on my ivory hat, researcher hat, it's mixed. We don't have a lot of good evidence either way. I think the important thing to realize, though, is that many people out there, including myself and our generation, we want quick fixes, right? If you look at the evidence for lower back pain, you should be going to physical therapy. How many people really want to go to physical therapy versus smoking marijuana or taking an opiate? You want quick fixes, and unfortunately the evidence is very clear on a lot of these chronic pain syndromes is that they really should be in therapy, manipulation, mindfulness meditation, all that stuff is there. But we, number one, insurers don't pay for it on a longitudinal basis, and people don't want it. They want a quick fix. And there is also a movement in the marijuana world is that it's something against the medical establishment. Patients don't like doctors. They don't like to be told what to take. They want to take what they want, right? And so I think there's a mindset about that, and that's one reason why this is so politicized.
Okay, so this question is for Dr. Gordon.
Oh, no.
In 2011, Weiss and et al. In I think it was General Psychology, they did a study and they proved that buprenorphine has a 92% recidivism rate, and with the current trend with medical assisted therapies, my concern is that we're getting more away from the traditional process therapies and more into the medication, and it's creating a real problem, I think, for a lot of the clients that are on that process.
That's a great comment. I want to make sure that as I purported to talk about medication treatment, it's not for everybody. Actually, the vast majority of evidence out there is that you don't need a medication necessarily to get better. That being said, some patients do need it. The recidivism rate actually is much less than what you were quoting. People actually do pretty well if you're in treatment and longitudinal care, and actually you can continue that care, which is a big problem in the United States, is that many insurers don't pay for it for a very long time. People do very well. That all being said, remember, not all treatment, whether it be medication or non-pharmacological therapy, is good for everybody. You have to find, we as providers and the population need to find what works for that specific client. I do really appreciate your idea. There's just there's some negativity toward medication treatment, particularly in people who have done really well without it, or in treatment programs which don't have the capabilities of actually providing it. And I think those are the things that we just have to recognize, and also say that there's options for that patient that go there, or there, or there, but let's find the appropriate treatment program for that person.
Maybe one more question.
This is quick and dirty.
Oh no, dirty urine.
Long as 30. Sorry.
Thank you. A few years ago, I have a sister who was addicted to opiates, and she died of an accidental overdose.
Sorry to hear you.
She had been doing better than she had in years because she was going to a methadone clinic once a month. So, to get her meds once a week or something. What my biggest question is, if they're already on methadone, can you overdose on just methadone?
Mm-hmm.
I was wondering, I don't know where she would have gotten something else because she was so broke and didn't have transportation.
Yeah, so great. So the question, I don't know if you all heard that. So I'm sorry to hear about her. She was doing methadone. She actually had got to the provision of actually getting on a weekly or monthly basis based on her success in doing the program, and then she overdosed at some point. And your question was, can you overdose on methadone? Actually, methadone is a very scary medication. A lot of the overdoses that we saw early on was with providers, primary care, who was using methadone for pain, and we're titrating up very quickly, and that's not how you do methadone. Methadone, it has metabolites that are very active, and you can actually overdose on it very quickly. You can also do it within treatment, right? So if you're in a methadone program or even in medication treatment within office-based setting, I mean, part of recovery is not only just getting a medication, but also providing those recovery supports around her or whoever. And so I think, that's why I mentioned earlier is that this is all collaborative, right? We shouldn't think of this medication only versus that. We should think of it all as a continuum of care, and or maybe people need all different types of things. But to answer your question, yeah, you can't overdose on methadone. It's hard to do it in methadone facilities if you get it on a daily basis because they give you an aliquot of liquid methadone, so it's very difficult to do that. But for take-homes and stuff like that, people can overdose on it. That does happen.
And kids get into it at times
Yeah.
too, right? Which is
Yeah, kids.
heartbreaking.
Yeah.
Before you say your concluding remarks, we'd love to have more questions, so I'm up here for a while. The other thing too, I really want to appreciate this conference. It's great to see everybody here at late on a Friday, and we will appreciate that. That's what we need to be talking more and more about these issues in our, whether it be healthcare professions or in the community. So thank you all very much for being here.
I forgot to go. Did you have a question still? I forgot to go. You're good?
There was a question regarding stigma.
Yeah, we want to hear it. Let's do it.
Yeah, if you got it. I spaced it. I apologize.
So there was a question regarding stigma when doing groups with patients. So one of the problems I would have with doing groups, and Dr. Tonigan had made a joke about it, and I would get it all the time. What's the difference between an alcoholic and an addict? But also, you would get between heroin addicts who were snorters and shooters, they would also divide groups. So one side would sit on this side, one side would sit on the other side. So with that stigma between addicts, how do you fight that stigma amongst addicts?
So that's a great comment. It's very similar to some of the comments we've already heard today. Even among healthcare providers, we have the abstinence-only people versus the harm reduction people, the medication treatment versus people versus the, to fight that stigma, you got to realize that everybody's coming to treatment or to a group setting in different pathways. And how do you fight it? You embrace it. That's how I do it. So if I'm in a group setting and I'm helping people out, I want people to talk freely and make it an open space so that everybody can bring in different perspectives. Especially if you are building the model where these groups are mentoring not only people in the group but also potentially other groups down the road. And you say you have to be open to different experiences that people have, just like healthcare providers should do the same thing. And be open to different modalities of treatment. I think that's the message that I would do.
And if you can get somebody to drop into their heart, even if one person in the group starts to do it, if you find a strategy, once you get to the heart, then there's more of a universal feeling there, and they start to look past who uses what drug and how, and they start to feel each other's humanness. Like the gentleman today who started talking to his inner child, that couldn't help get to everybody's heart. And sometimes you get a technique or you use a strategy that opens even just one person up, and sometimes the heart's open in the group in a way that starts to mitigate those boundaries. It's been my experience.
Realize there's a person. Do you have? Yeah, go ahead. Yeah, I was.
He was thinking about it.
They're addicted to addiction.
You just can't stop.
Sorry for being
Just
annoying.
one more.
I just had another question. I actually asked Dr. Kemp this earlier, but I wanted some more feedback about it. I have a client that is using meth and heroin, primarily meth, because she sees it as not as dangerous. But she's not really interested in doing anything different. Her mother is paying for her to come to therapy because her mother's freaked out about it all. But she'll come high. And I don't know if it's appropriate, like I don't want to be enabling this person to keep coming, but I feel like I'm the only person that she actually will talk to and get vulnerable with because I use horses and she'll come and interact with the horses. So there's a key there but I don't want to shut that off because I know that connection is a big part of fighting addiction, but I'm really worried that if I say, you know, you have to be sober to come, that either she's gonna flip me off and go the other way and think I'm just somebody else who rejected her. And I don't know what to do with that. It's not something that I haven't really faced before with somebody who doesn't think it's a problem. But, you know, behaviorally, you know, she's robbing everybody blind in her family, so they've all kind of shut her out, except for her mom, who's willing to pay for therapy and gas to get her to come see me. But I don't want to be being manipulated either by her, so.
So I'm not going to answer that question, but I'm going to ask you all that question. So how many people out here would say that person doesn't need to go to her anymore and should like leave? Cut off. How many people would say, hey, you know, I'm thinking of alternatives here. The alternative is continue doing what you're doing, engage in as much as you can. Even though that client or patient comes in high, I'm still going to talk to that person. How many people would do that? Wow.
It's a lifeline.
You know, that's a lifeline, right? And or maybe say, I can't. How about the other contingency kind of approach? Like you would say, hey, I'll see you, but only if you do something else. You have to go see someone care. How many people would do that? That's another. What other things would you do? Yeah. Okay. So some dangers, some boundary. But you would say if you're under influence, you cannot see me. And okay, what other things would people do? You know, by the way, what you just did is so much different than 10 years ago. 10 or 15 years ago, almost every hand would say, "See you later." Right? And it's really remarkable how we changed our culture. What's that?
She said that's what the DBT model says.
Oh, yeah.
There's kind of that, you know, if you're self-harming, I won't see you because then you talk about self-harming the whole time.
Right.
I talked to her about that when I met with her the other day, and I said, I don't want to talk about using anymore, I want to talk about other stuff. But when you come high, we have to talk about using, which is whole.
Any other thoughts out there? What would you do?
Maybe one, and then we got to wrap up.
Stages of change.
Stage of change. So motivate. Kind of go from a pre-contemplative to contemplative stage.
And I am sorry to cut it short. I'd love to keep going, but I just want to respect people's time and everything.
Thank you, guys.
Thank you for coming in. Just real quick, I just wanted to thank again just all you guys for taking some time to come and do this. I appreciate everything each of you said. Dr. Tonigan had to go to catch a flight, so he had to go out a little early. But something that stood out to me as like a common theme is, you know, with the about access to care, medication-assisted treatment, community-based self-help, mutual aid groups. There is a need to address, and you know, when you do have them, you know, some of these techniques we looked at a group, we're trying to find a way to keep them and engage them, and when you have that opportunity, it just kind of reminds me, you know, we're dealing with some people that are in a tough spot, and they just need people that are willing to try to help them, and you know, I think the humanness in a lot of this brought out, and I really appreciate Mark being willing to talk about the pain you've experienced with your daughter, questions regarding family members and people standing up to acknowledge that, you know, we all are affected by this in some level. So thanks again for coming.